Following our previous neuro-ophthalmological videos, visual field defects, diplopia and gaze palsy, we will talk about nystagmus today. What is nystagmus? The definition is rhythmic, involuntary, rapid, oscillatory movement of the eyes. There are few conditions where the eyes will be oscillating, but it's not exactly nystagmus. There are mimickers, namely ocular bobbing. It's like bouncing ball up and down movement with equal velocity. Coming to opsoclonus, it's a random eye movement in different directions. You can appreciate sleep as soon as the real patient. It moves. Number 3, saccadic intrusions. Here again, the eyes are not fixed in neutral position. Ocular flutter. It looks similar to saccadic intrusion. It's an intermittent jerky horizontal movement of less amplitude. And if you identify nystagmus, you usually have fast and slow components, except in pendular type. Nystagmus can be triggered by various gaze positions like lateral or upward and downward gaze. For example, leprechaunism nystagmus is aggravated by lateral gaze, vestibulo-ocular reflex during the head movement, but it can trigger certain types of nystagmus like vertical nystagmus. Coming to the symptoms, is a setting of nystagmus. Number 1 is oscillopsia. It's nothing but jumping images. Number 2, blurred vision. It's due to lack of appreciating depth of images. Vertigo is an illusion of movement as environment appears as rotating around. The vertigo is a symptom which is essentially due to a mismatch between the visual clue or signals from the eye, or vestibular or labyrinthine signals, proprioceptive signals from the neck muscles, joints of limbs or trunk, etc., in relation to the orientation of the head and body position in the environment. So the brain integrates all the information every second so as to keep the body and head in an environment very appropriately. So if there is a mismatch, you get a vertigo. That's what happens in the setting of nystagmus. The patient may have a toxic gait. What are the clinical types of nystagmus? The horizontal is a faster component is towards the left and slower component towards the right. Horizontal because you can see the faster component to the right and slower component to the left. Vertically, the faster component towards up and slower component towards down. Downward nystagmus, you see the faster component is towards down and the slower component to up. Pendular, it can be horizontal or vertical, but the oscillations are at the same speed on either directions. Rotational or torsional nystagmus. You can see the intorsion is faster than the extorsion of the eyes. Seesaw nystagmus. So one eye moves up and the other eye goes down at the same time, like seesaw. Rotating drums test, a rotating chair test, and the lips. It's a big test. Suddenly turn the head to one side and see for nystagmus. And the last one is called caloric water testing. We use hot and cold water with particular temperature which is tolerable by the patient. And if you push cold water into both ear, external canal, the temperature adjusts the tympanic movement which is transmitted inside to the vestibular system, and that provokes a nystagmus. When you push the cold water, and the nystagmus appears to the opposite side, whereas the warm water moves the eye to the same side. Now we have to rule out the congenital nystagmus promptly. Children less than 3 months, albinism, poor optic nerve development, congenital cataract, strabismus may cause nystagmus in children. Which is usually a pendular or multidirectional nystagmus. Whereas the pathological nystagmus are quite different, which can be due to peripheral causes or central causes. You should ask few questions. Whether the patient has got history of vertigo, which is severe with vestibular, but mild in central type. The patient has got pure horizontal nystagmus without torsion, it is central. Mixed nystagmus with horizontal as well as torsional is common with peripheral, as vestibular cause than the central cause. Coming to the symptoms, it's recurrent self-limiting episodes seen in peripheral, but it's usually chronic. If the patient has got additional ear symptoms like tinnitus, which is pointing to vestibular. If the nystagmus is purely vertical or torsional, it's typical of central, very diagnostic, but it's rare with labyrinthine. Visual fixation dampens the nystagmus in labyrinthine, whereas there is no change noted with visual fixation sensor. Coming to Dix-Alpix test, the nystagmus appears 2 to 30 seconds after hypnosis, whereas in central type, the nystagmus starts immediately and it lasts for more than 1 minute during the testing. Now coming to topographic anatomical localization. If you take horizontal nystagmus, it is usually vestibular etiology. If you take downbeat nystagmus, lesion is usually the cervico-medullary junction tumor, cerebral malformation, cerebellar floccular lesion. Upbeat nystagmus, the lesion lies in posterior fossa, caudal medulla, damage to ventral tegmental area and anterior cerebellar vermis. Torsional nystagmus, the lesion lies in the brainstem. The seesaw nystagmus usually has a problem at the diencephalon paracellular region, or pituitary or optic chiasmal lesion. If you take pendular nystagmus, it is usually due to blindness, optic neuritis, multiple sclerosis, brainstem or cerebellar lesions. You see the dissociated nystagmus. This one eye has the fascia covered to the one side and the other eye is traveled to the opposite side. And the lesion lies at the medial longitudinal fasciculus. Now we have seen the various types of nystagmus and possible anatomical localization. And we'll see the etiology of peripheral nystagmus, usually labyrinthitis, Meniere's disease, and drug toxicity with the use of aminoglycoside, phenytoin, phenobarbital, quinine, carbamazepine, or salicylates. And important causes of central type of nystagmus, usually demyelination, vascular hemorrhage or infarction, vertebrobasal insufficiencies, tumors, or even malformations of usually the brainstem region. To summarize, identification of the type of nystagmus is important, and we need to exclude other eye movement disorders. And congenital nystagmus, we need to find out whether it's a peripheral cause or central cause for the nystagmus. Then we need to make anatomical diagnosis, and then by investigating we need to arrive at etiological diagnosis. Remember that certain nystagmus is medically treatable nowadays, like upbeat nystagmus and downbeat nystagmus. Thank you.